Very good morning. Today from Bhotiapara, we are going to do a CME, a different CME. And we're going to talk about diabetes and we're going to talk about how to treat early. We're going to treat wisely our patients with diabetes. You see, if you look at the problems that are with diabetes, the major problem is that patients have got uncontrolled diabetes for a prolonged period of time. Even 1 year of uncontrolled diabetes significantly increases your risk of myocardial infarction, heart failure, stroke, and composite cardiovascular events. An increase in the cumulative evidence of nephropathy by 16%, neuropathy by 8%, and retinopathy by 7%. It's very important to understand when a person is diagnosed with diabetes, 50% of the beta cell is already lost and the risk of cardiovascular is enormously increased already the time that they are diagnosed with diabetes. If I take a silk, nothing sticks to it, nothing passes to it, and a normal person's artery is like that. Whereas the moment a person becomes diabetic, the artery becomes like Velcro, very sticky, and that increases the risk of cardiovascular and arteriopath incidence of patients with diabetes. So it's very important to understand that we need to treat the patients quite early so that we can reap the benefits of a better and a longer good control of diabetes with reduced risk of complications that are there. See, we all love our family. Our families are becoming small and nuclear families. If you need to understand, say you're sitting in the garden with your family and having a cup of tea, and a snake creeps up in the garden. Are you going to wait for the snake to bite you, or are you going to kill the snake first? Similarly, to understand that once the diabetes is there, we really need to handle the diabetes quite fast so that there is no onset of the start of micro or macrovascular complications, so that fall of HbA1c and reduce the risk of both cardiovascular and other microvascular and macrovascular complications. Because achieving early glycemic control may generate a good legacy effect, which has been shown with UKPDS studies, ACCORD, ADVANCED, EDIC, and post-UKPDS outcomes. So where is the problem with all this knowledge? There is clinical inertia. The inertia can be at three places: at the physician level, at the patient level, and at our ecosystem that looks at managing diabetes. If you look at the physician level, you see the patient comes to them and there is a delay in the onset of starting to treat very aggressively, reduce insulinization, and the patient dithers on with complications, because it's always a fight when we have with our patients when we start insulin, because insulin has so many myths that are there. People fear insulin. The moment the word insulin is uttered, 50% the patient may disappear from their clinic, and there's a risk. But one needs to explain to the patient that insulin, the diabetes happens because it's an insulin problem, and that's why we need to tackle it to the root of insulin and bring a better control of the patients. As I said, there are a lot of myths and factors that a patient may have heard from a wide variety of hearsay or their relatives about, early insulinization, and this needs to be discussed with them. Even our healthcare system, ecosystem needs to be changed. We do not have a very well structured primary, secondary, and tertiary care with referral system, and we need to evolve, but we need to find a solution in what we exist, because things are not going to change in one fine day, and we need to strive towards changing by getting, creating awareness, creating education programs, and creating upgradation programs for clinicians as well as patient support groups which can understand the impact of diabetes. In Hindi, I said diabetes is like a Dimak that eats the body up. So we need to really get control of our diabetes so Dimak doesn't affect our body at all. And we need to explain to the patients the adherence of medications, the effective use of informations, and the clinicians about using guidelines. Now, there has been a change in the management of diabetes. We are no longer looking at the care of diabetes from a glucocentric point of view. We are looking like a holistic care of diabetes, and that is where the guidelines have been upgraded now to look at the holistic care, taking in view the patient perspective, because the shared goal approach with the patient that is there. And this multifactorial approach helps us control better and in tandem with the wishes of the patient. Because we need to understand the priorities of the patient, we need to understand the limitations of the patient, and we need to explain to them when the microvascular and the macrovascular complications have happened. Now, if we look at, we need to look at the recommended targets for patients when they come to see us. We need to look at just not the glucocentric, that is HbA1c. We need to look at the cholesterol. We need to look at the creatinine in the urine ACR that is there. We need to classify them into mild, moderate, or high risk. We need to look at their LDL cholesterol. We need to strive to them to improve their lifestyle and better quality of life with exercise, with understanding of the eating patterns, so that we can bring about this revolution of good care of diabetes. If you look at various guidelines that have been changed, there's been a multifactorial intervention that is there. So the concept has evolved from HbA1c now to HbA1c with improvement in the cardiovascular risk, including blood pressure, cholesterol, and glucose lowering agents with evidence proven and things which has got more benefits other than just glucose lowering agents. So if you look at the ADA standards of care and other ESD standards of care, it has evolved. Now we look at the patient and we look at whether this patient has got kidney involvement. They've got kidney involvement, they're leaking protein. SGLT2 is a good marker to start with if there are no contraindication, and if they are not contraindicated, or if they're contraindicated, if they've got problems, you can add in a GLP-1. If patients has got weight as a centric problem, then GLP-1 with proven benefits are good. If they've got a cardiovascular component, we need to look at SGLT2 or GLP-1 as a proven cardiovascular benefit. We need to look and tandem the patients with the benefits with maybe adversity which may limit the limit of this outcome to achieve a holistic outcome, understanding the total indeterminants and determinants to achieve them to get it. We need to explain to them the role of insulin and the proposition of cardiovascular management goal, because only when we agree to have a common engagement and management plan, we can achieve this fight against diabetes and make our patients live and deserve the quality of life that they truly deserve. With that, I thank you all for your patient hearing.